Hi, so welcome to the Research Literacy Networking Zone. This is just a nice conversational space where we can come together to have a discussion with researchers about the science of the day. And in particular, today, we're going to be talking about maps, models, and measurements, so sort of new ways to assess the social determinants of HIV. And we are really excited today to be joined by three experts, Dr. Greenwood from NIMH, which is the National Institutes of Mental Health, Dr. Marie Stoner from RTI International, and Benjamin Young. I'm sorry, can you please help me pronounce your name, Benjamin, please?
It's Byungjun Kim.
Byungjun Kim from the Columbia Mailman School of Public Health in the epidemiology sector, who have presented some really great research on a new initiative that the National Institutes of Mental Health has put forward. So we do want this to be a dialogue and a conversation between everybody on the call today. So we encourage you to use the chat feature to ask your question, or if you feel inclined to raise your hand and we can ask a question directly to the speaker. But I will kick us off with first, maybe just Dr. Greenwood, can you just talk a little bit about the new initiative that NIH has actually funded and why the NIH thought that it was time for sort of a reimagining or to innovate some of these strategies for measuring the social determinants of health?
Yeah, thank you so much for the invitation, and it's great to be here with you and everyone else. So the initiative around social determinants on HIV, as you mentioned, Jessica, as the landscape in prevention and treatment, really accelerates and expands, and there are evidence-based prevention and treatment available, the need to implement and realizing that in the implementation that there are inequities in the rollout. So NIMH came together with the National Institute on Allergy and Infectious Disease back in 2016 to bring together an RFA that focused on the social determinants of HIV to really advance methodological and data analytic tools that would really enable researchers and community partners to understand kind of where and how social determinants of HIV impact uptake, access, and so on of HIV prevention and treatment. And so back in 2016, the RFA was released. We funded 6 different research teams that cut across kind of these topic areas, 2 studies around modeling, 2 around developing new geospatial mapping approaches, and 2 around longitudinal measurements, all trying to look at what's the relative contribution of these different determinants on HIV outcomes. We then held a workshop in 2019 to kind of look at the progress, and then now in 2021, as we speak, there will be an AIDS and behavior supplement on this special issue to help inform research and community partners. So I'll stop there.
No, that's great. And I think for me as maybe somebody who's a newer advocate in this space, thinking even more deeply about implementation, this idea of the use of models for this has been a little bit opaque for me. And I think that COVID has really sort of solidified what is the model and how it can be used. And I'm going to talk to Dr. Stoner first, because I know that your work in particular has thought about using models in a new way. So I'm curious, maybe just to talk a little bit first about your actual project about, modeling around cash transfers with the group. And then I'll ask a little bit more about, how do we think that this could be scaled up in other countries? So first, maybe just describe a little bit of your research.
Yeah, so just to provide some context, the research that I presented yesterday was part of a larger project that's been led by Audrey Pettifor, where we now have like 9 years of follow-up on adolescent girls and young women in South Africa, and have been able to really understand HIV risk as girls transition into adulthood. So we've used that data first to really understand different social factors and that might influence HIV risk and how they operate. So for example, we've seen a lot about different social network factors, like the importance of parental monitoring and having a safe supervised space for young women, and also partner characteristics like transactional sex and age disparate partnerships. And then mental health has also emerged as a really important component. So depression and also trauma through the experience of violence have been associated with HIV. And sort of as a next step of that, we've been trying to do work where we've been looking at combination prevention intervention. So now that we know these things are associated with HIV, like what are the different combinations that we can put together to have the biggest impact on reducing HIV incidence in this population? And so I presented some work that we've been doing along those lines about cash transfer interventions, because the literature seems to show that they've worked in some settings, but not in others. It's a little bit mixed, but they might be more effective when combined with other types of support. So we did an analysis that was looking at combining cash plus like 5 other different psychosocial factors to sort of like hone in on, well, what are the most important things? And we found that combining cash with reducing adolescent depression and increasing parental care would have the largest impact. And I think it's important because when we start talking about combining these different social interventions, I think there's you could end up with just like a huge package, really resource intensive. And we've been using different methods, and particularly causal inference methods, to try to like hone in on what's the biggest like bang for the buck that we're going to spend, and in terms of what could have the biggest impact with the smallest number of interventions.
That's really helpful. And I guess there's a couple of pieces in there at AVEX. Some of the projects that we have worked on in our product introduction team is around this idea of empowerment with women. So when you talk about depression, reduction in depression among the participants, could you equate the same thing? So reduction in depression is also equal to the empowerment of AGYW and the feeling of being able to take control over their lives?
Yeah, I do think that is really important. And I think that's also come up with some of the work that we have done in cash transfers, showing that having access to cash can help young women feel more empowered and have more control over their decision making and sexual relationships. And I think also mental health really plays into that, and thinking about settings like in South Africa, where there's a high experience of violence at a young age. And I think mental health is really important, and thinking about health in sort of this more holistic way, where if you're better, like feeling more mentally better, and I think you're able to form more healthy partnerships and think about relationships in a different way too, especially thinking about younger women who are also maybe more vulnerable to begin with in terms of trying to develop their first relationships and having like new experiences with partners.
Great. So there's 2 questions from Nintendo coming into the chat, and I will circle around to the sort of initial question first, but maybe Dr. Schoonover, we still have the floor with you. You know, is there a difference between cash transfers and economic opportunity? And is it economic opportunity sounds like an encompassing phenomena as opposed to transaction?
Yeah, so I think about cash transfers as falling under two different broad categories, but I think economic opportunities, they are economic opportunities, but I think there can be other types of economic opportunities as well, like starting starting a business or microfinance. But cash transfers, in the way we've been thinking about them, have been either studies like the HPTN 068 study that we've used, where cash was given to young women in their households if they attended school. So more programs that provide cash, either conditional on some type of behavior or just without any conditions. And then I think the other type is grants from the government. So for example, in South Africa, there's the child support grant, which is a grant that's given to relatively low income households to help with the costs of childcare. And there are no conditions on that. And so I think that's another type of cash transfer. Even in the US with COVID, there's been like types of cash transfers where households have been given money to help with the costs of the financial burden of COVID. So that's sort of what I think of when I think of a cash transfer.
Great. And I think I want to dive into that a little bit deeper later, but before we kind of get into some of these meatier questions about how advocates can use some of this new data, I want to go back to Ntato's initial question, and I'm going to throw this to you. I think I'm going to throw this to you, Dr. Greenwood, about what was missing. So this question, it's apologies for Jay, kind of, but it's interested in what was missing in the knowledge we have around the social determinants, and are they different from social structural drivers of HIV?
Yeah, thanks so much, and thank you for the question. And I'll start with the latter. I think when we, our group, as we were thinking about social determinants of HIV, we were thinking about kind of social structural drivers, including economic conditions, different positions that one may find oneself in, whether a position of advantage or disadvantage, for example, or systems of oppression. So it's kind of broad around social structural drivers of social determinants of HIV. What was missing from in our viewpoint was that a lot of studies crudely measured social determinants. And so there was a question mark around the validity or even the precision of measures. And Dr. Kim will be able to kind of talk about, the importance of mapping physical activity space versus residential space. A lot of the HIV literature around neighborhood impacts focus more on residential neighborhood and not on people's activity spaces. So there were issues around measurement. There were issues around what's the relative contribution. So we're all familiar with the socio-ecological model, where there's these concentric circles of influences from individual and out to, the societal social drivers. And oftentimes the social determinants are really in a list format, and there's not an appreciation for which has the greater weight and how it works. I think Dr. Stoner kind of talked about the what and the which and the how. And so this RFA was designed to really encourage careful, longitudinal, non-intervention research that used new measures, new methods, new data analytic techniques to really look more from a causal standpoint, which social determinants and how are they connected, do they impact outcomes? And maybe just one last example. So Dr. Blankenship study is around the intersection of housing stability, housing policies and incarceration, and looking at that intersection of people who are living with HIV, who've been in the criminal justice system, who experience stable or unstable housing, and who have to navigate these very complex and very restrictive housing policies. And so the RFA was designed to really try to untangle those influences. So I'll stop there, Jessica.
No, thank you so much, Dr. Bruno. I think this is such a helpful framework. And like I said, I think we're all, especially myself, kind of stepping into, how do we take all the interventions that we have now and really make effective programming? And with that, I will turn my next question to Dr. Kim. I will just, the GPS studies were something that were kind of new to me, and thinking about how do you think about the difference between where somebody, where they live versus where they play, and how that impacts, effective programming. So first I'm going to ask, can you just explain the idea of GPS and what that means in relationship to the social determinants?
Okay, thank you for asking the question. So when we talk about social determinants or social environment in terms of HIV risk, we usually focus on the residential areas of the participants or the patient, because so we had a prior research on the location of PrEP clinics around across the New York City area, and we found a very strong association between the number of at-risk population, especially the people with the HIV, with the number of PrEP clinics in the city. So that is partially because of the implementation strategy from the New York City Department of Health. They actually look at the surveillance data based on the residential area of the participant or patient. But actually, when you look at individual level data, people don't just stay in the one residential area all the time. They travel around the city and then travel across different cities. So when the most of the people, they stay home during the night or afternoon hours, but actually they just go out and then just do other things during the daytime. So we think that it is really critical to think about the mobility patterns of individual to actually or accurately capture the contextual factors of HIV risk. So that is our point of view, to think about the dynamics of individual, especially in terms of the HIV risk. And Dr. Dustin Duncan, the PI of the project, we started to look at utilize the GPS device to track the people's mobility pattern and daily mobility patterns. So we tried to analyze the GPS data for many different ways. The first paper project we looked at was the actual accessibility, geographical accessibility to PrEP clinics and their uptake. So there's many different projects we use from the GPS device, but there was the first one, and then we also analyzed the mobility pattern and then the level of personal mobility in terms of the sexual risk behaviors. So I'm happy to discuss more about the details of the project. And then anyway, the overarching theme that we are looking at the mobility pattern is that people do not stay at home 24/7. We move around the city, and we need to actually capture these different types of neighborhood exposures from different neighborhoods.
I mean, it's so I do want you to go into the study details a little bit. I mean, it seems such an obvious thing, right? Nobody just stays at home, right? You go out into the world. And so how do you think about that in relationship to risk and how you create a program around it? So maybe you could talk a little bit about what what the study found here as well.
So,
and talk a little bit about, you haven't mentioned the population yet that you've actually working with.
Mm-hmm. So our study participants, they are young sexually minority men in the city, in New York City area. So we used the GPS device for 2 weeks and then we created this activity space from the GPS data, meaning, so when you go to some other places, we have the tracking points, so we can create where they go, and then we can generalize the activity space within the individual level. And we compare the number of PrEP clinics, PrEP prescribing services in the city within the activity space, as well as within the census tract and the zip code around the participant's home address. So we found that the number of PrEP clinics in the activity space defined from the GPS device, there was a positive association between the number of PrEP clinics and then PrEP uptake. Whereas the number of PrEP prescribing services in the zip code and in the census tract, it was not significantly associated with the PrEP uptake among our participants. So that means, so when we are trying to think about the implementation of PrEP implementation, then we should consider the mobility patterns of individual rather than just look at their residential area, because we can pick up the medicine from our work or from other spaces, from other neighborhoods, but it doesn't have to be necessarily within the residential area.
So it's not where you live, it's where you play. That
That's
matters.
right.
So there's a really great question from Peter coming from the chat, which is the use of GPS is really interesting. Can you talk a little bit about the privacy, the accessibility, and other factors associated with privacy?
Oh yes, so the privacy is like a really big concern of that study, because you can actually see where they go. So we try to de-identify the study participants' name and other identifiable variables from the GPS data, and then only a few investigators can just link the data set with the survey data and the GPS data, so that we can ensure that the privacy of the individual is not going to be, it's going to be secured within our team.
Great. Thank you. And I think we'll kind of talk, I do want to dive a little bit more into what are these ideas and how do we implement them? And I think maybe going first back to Dr. Stoner, because there have been a couple of questions around the cash transfers that have come in. So maybe first we can just go with John Keith. Has there been research done in how cash transfers function or impact AGYW in the face of gender norms?
I think that this is a really good question, and I'm trying to think about the literature that I know in this area. There has been a big focus on whether or not cash transfers can impact transactional sex in particular. So having because maybe cash can give women more financial freedom and make them less reliant on a partner, does that reduce transactional sex? And the literature does seem to be sort of mixed in that area. And I think that it actually might also have to do with the comment above about cash and how cash can sort of impact some things, but maybe not others. And I think that thinking about cash plus care or other social interventions are important, because cash, I think, can help with some impacts of social determinants, but maybe not all. So providing cash with other support, like to increase skills or empowerment or parental support, can, I think, really increase the impacts of cash, and maybe even providing cash in reducing gender norms could be another combination that we should consider that we haven't yet.
Great. Tando, I see your hands up.
Yes, thanks, Jess. I think I would like, I'd like to sort of maybe give even more clarity where my question is coming from. And I think, I appreciate the example about government giving grants, social grants. And of course, there is a lot, I'm in South Africa, there is still a lot of debate around that. And I'm very much interested basically to bring the two concepts. One of the things, even with biomedical interventions that we roll out in communities, as advocates, we have fought the idea of these interventions seen in isolation of the broader context, which I guess that's the reason why we're talking about the social determinants of HIV. And I think that's one thing, I have that strong feeling around cash transfers, that it's coming from an idea that young women are being exploited by working men. And in fact, what I hear less of is the context in which this is happening. This is happening on a Friday afternoon when there is, a lot of, at least at the most, Friday partying, weekends, and so on. And that exploitation happened in the context of wanting to have a great time and a great weekend. However, we talk about it to be providing, for instance, for the family. And I think for me, there's a serious gap around that. And that's what I'm really trying to get to.
Mm-hmm. Yeah, I think that's a really good point. And I think that it also, to me, further sort of supports this point, which I very much agree with, that cash maybe shouldn't be given in isolation, and we should be thinking about it more in combination with these other types of support that can be addressing some of the other components of social determinants that are also important.
And maybe Dr. Stoner, can you actually just lay out, because I don't remember you specifically mentioning the other elements that you put into combination in the model that you were looking at? Because I agree with you, Tando. I think that, you can't just talk about it in isolation. And I think, what Dr. Stoner's research has sort of shown, and Audrey Pettifor over this long history, is that it is a mixed bag when you give it individually. And this is what HPTN 068, really said, is that you have to see it in combination. But I think when we think about how do we implement those programs, it's a little bit like throwing spaghetti at the wall, for lack of a better phrase, right? You kind of have to figure out what is the program, that is going to work. And so first, Dr. Stoner, maybe you could talk a little bit about you could just say the pieces that you looked at with your model in conjunction with cash transfer. And then maybe we can get a little bit into the discussion on how could you apply this? What could advocates learn, take away from this?
Mm-hmm. So yeah, we started with some of the things that we had found to be associated with HIV previously. So we looked at cash plus, parental support, because there's been other studies that have looked at parental support and how the importance of providing parental care in combination with cash. And then we also looked at depression, so reducing depression, because we found that to be associated with HIV, and also age disparate partnerships, transactional sex, and school attendance. And so those were the things that we looked at in combination, although I think there could also be even more factors that we weren't considering that could be really relevant. And of those, the things that came out were cash plus parental care plus reducing depression, which I think is important. And I feel like I'm still trying to think through why these things and why are they important. And I think it might also have to be with sort of the pathways and the ways that they affect HIV and work together. And so definitely, I think the strongest two combined factors were cash transfers plus parental support. And I think, to me, that might have to do with providing cash to young women in a household where they have a parent who can make sure, is helping to spend the money in ways that will benefit them, or helping with sort of other components of reducing HIV risk is extra important. But I think it is hard to, with all these sort of overlapping social determinants and interconnected relationships, really understand what's happening. And I think that is part of the importance of all the work that we've been doing towards social determinants, is to try to really hone in on what are the things that are the most important, and how are they connected, and how to most effectively reduce HIV risk.
Go ahead, Dr. Greenwood.
Yeah, thanks so much. I was just going to say that everything that the gentleman Natando is offering and Dr. Stoner is discussing, one of the themes from this work, and it will be reflected in the supplement, is the central role of community in this work in social determinants, and working with the researchers around framing the right questions, understanding the literature, helping to decide on the methods and tools of investigation, and in interpreting results. So I think Dr. Stoner was just saying it would be interesting to have a discussion about how cash transfers in parental care were so relevant, or for Dr. Kim's work, in terms of mobility patterns and what happens kind of person, place, and time. What are the factors, the place or the environmental factors that really impact kind of the uptake of PrEP when it's more accessible given your mobility patterns. So for me, a lot of this discussion so far really helps to underline and bold the importance of stronger community research partnerships in this area of research. So thank you.
No, so that was actually going to be my next question, is sort of how does community ensure that this doesn't sit on a shelf? But I think maybe before we get into that discussion, we're talking about 2 studies in isolation, but this is sort of a whole body of work, and the session itself did talk about, as Dr. Greenwood said, six sessions, and one, which we don't have the presenter here today, Dr. Ben Haywood from UCS, did have a study on looking at the difference between how housing, your stability of housing impacts HIV rates. But one of the points that sort of came out of that was that, the window in which you actually look at risk behavior has normally been 7 days, but it's actually, we should be expanding that, the window in which we look at risk behavior to something much longer. And so I want to ask Dr. Kim, in sort of thinking about just this new way to measure risk behavior, how does that impact how you think about the way a person moves through society? Because you looked at a 2-week window of GPS data, and Dr. Haywood is thinking about a 90-day retrospective look. So how could you actually think about that in relationship to your work, and would it change it at all?
So I think that critical theme here is that whether the risk behavior or mobility pattern, they are generalizable from the survey data or GPS data. So for the risk behavior, I think there should be some extended window, because of the short time window cannot be generalizable in the population. But for our GPS data, so there were lots of previous studies using the GPS data mostly for obesity-related behaviors. And from this previous research, they said that 2 weeks of mobility pattern could be generalizable for that time of that life course. So most of the time, the GPS device, they mostly use like a 1 week of monitoring window. But for our data, we tried to expand the generalizability so that we expanded the days of the data collection for 2 weeks. And that is one strength of our study compared to other GPS-based studies. So I think the most important thing here is whether the survey measure, or it could be some other quantitative measures, but whether we can generalizable that exposure or risk behaviors for the population we are looking at.
So and this is really a question to everybody on the call today. This isn't just for the panelists, but how does community and advocates, how do we ensure that these data and this information gets used? And I mean, we can talk specifically about cash transfers and maybe some of these geospatial or the GPS work, but just how do we ensure these tools are taken up in community partnership? And for those who didn't attend the session, I will just say at the end, there was a strong call actually for a new network that looks at the social determinants of health exclusively, that would sit alongside HPTN, HVTN, and that this would be, and I don't know what an acronym would be for it, but I guess HSDN, that would sit alongside as like a real place. So how does community, as advocates, how do we take it up to make sure this doesn't sit on the shelf?
So I guess implementing like taking into account of the mobility pattern of the people who are at risk is also have great potential to be collaborative community organization, because we know that we may capture people's mobility and understand where would be the best location for the implementation. So that doesn't really necessarily with the within the residential boundaries. So I guess the location of the congregation points or people who are the location where people hang out or shares a lot. There's lots of overlapped activity space of our participants. Then we should start looking at the community organization within that neighborhood, and then trying to think about how we can implement or how we can disseminate some knowledges in terms of reducing the HIV risk. So we thought about talking to the community organization in Health Kitchen in the city as well, because we identified some clusters of activity spaces in that area. So just it's not about like a downstreaming implementation based on the mobility pattern, but it has to be also collaborated with the upstream with the community organization in the neighborhood.
And I agree. I think that's so important because there is going to be a fear factor that kind of comes in with the idea that of GPS tracking, especially in countries where HIV is criminalized or where where being gay is criminalized. Like there's could be some real I think potential harms that communities could help navigate through. I also wonder about, Dr. Sterner, you did your research based in South Africa, and Dr. Kim, your work is based in New York City. So how do we think about the scalability and the transferability of some of this work into other settings? And Dr. Greenwood is somebody who's been thinking about this, as I know you have. Maybe the three of you can just talk a little bit about how do we adapt some of this work and make sure it's scalable and transferable to other settings.
So I'll answer this, I think, sort of from my perspective of being more of a quantitative methods person, but I think emphasizing the importance of working with communities and with the populations you're trying to reach, like adolescent girls, and for example. So I think from a methods perspective, at least now with causal inference, there are some really exciting new methods that could be applicable. Like, for example, there's something called a transportability analysis, where you can say, this intervention in this population reduced HIV incidence by 5%. So what would hypothetically be the effect if we use this same intervention in a different population with different characteristics? So sort of doing some modeling to understand maybe at a higher level what could be the effect of these different interventions and how they might need to be adapted for different settings. But I think that only gets us so far, as we've talked about. And I think another component of it is really having strong ties and relationships and with community members and with individuals that we're trying to reach who bring experience from their own, like bring perspectives from their own lived experience, and can also provide more insight into what questions should we be addressing, what things are important when we're thinking about adapting interventions, and how to interpret some of these results that we're getting. So I think that, to me, I feel like it's all about sort of the relationship and bringing in people with different perspectives and different skills, and even thinking about interdisciplinary fields like economics and mental health. And I think when we're talking about the social determinants, there are so many different things to consider, and having different perspectives brings like an innovation and creativity and new things that we need.
Yeah, if I could jump in and follow up. So at NIMH, you know, there's an ongoing discussion around how to encourage science that continues to move beyond the level of an individual focus, and so harnessing the tools, technology of other disciplines, bringing community to the center of the table to help discuss what are the questions, what are the designs, what are the research options, what makes most sense. So there's, for me, there's kind of four themes that stand out. There's community engagement, there's the implementation science, there's kind of a mixed methodological approach, like really combining the quantitative and qualitative to really understand. And then the fourth for me that hasn't been mentioned up to this point is kind of this intersectionality, taking an intersectionality framework around social determinants to really understand and intervene in ways that kind of reduce disparities and improve outcomes. I'll stop there.
So I really appreciate this discussion, because as somebody who's not a social scientist, I think one of the barriers perhaps to getting into this is that, the language in which we talk about this is so unfamiliar. It's so different than the way we talk about prevention. If you thought about for a long time thinking about, immersing yourself in biomedical prevention and learning, what's a dapivirine and what's a CD4 cell, the idea of a transportability analysis also all of a sudden becomes this sort of foreign piece, but yet is so important to the work that we do in making that tangible connection to how do we talk to the Ministry of Health about using this modeling data as an advocate to scale up programs. So, programs, or how do we get the Ministry of Health to use this GPS study to think about where do we put the next PrEP clinic or where do we talk to PEPFAR about funding a new clinic and its operation, and how do we talk about collecting data within our organizations so that we actually see risk. And I think that I'm wondering, just from your perspective, what are some of the tools or introductions that community and advocates can have to start thinking about and diving into this work so that we can help make it accessible and make it available for others in our communities? And it's okay if there's none. Maybe that's the project. Maybe that's what we have to create as advocates and community members.
It's not in terms of the HIV prevention implementation, but for other policy implementation. Actually, lots of cities, they held some kind of community workshop to identify some locations within the community with the community members. So they called it collaborative mapping, where so the community members of the neighborhood come together for a hearing or some community workshop, and then they start to think about where we should put some kind of implementations within the neighborhood. So different people have different perspectives, but it is really important to collect the ideas, how they perceive their neighborhood, and where are the point of locations for our implementation. So I think it is, the GPS device is not necessarily required for all types of implementation science, but I think the critical point that we are thinking is it is important to think about the different types of perception towards neighborhood from different people. So they may think that this location is too far from my neighborhood, but some people may think that it is within my activity space. So from some the collaborative work with the community members or community workshop, that it is really important to think about how people perceive their neighborhood and what is the boundaries or geographical boundaries can reach out to the people in the neighborhood. So yeah, that is one option, or one thing that I can think of how actually implement the geographical perspectives into the HIV prevention.
Great. Any other tools or any other resources that we can think about to, like I said, help bridge this gap, but to bring advocates and community into this space so that it's accessible to kind of talk about how important these new tools and methods are, and again, to make sure that they don't just sit on the shelf. And the shelf being, researchers will use them, but how do advocates take them to policymakers? And yeah, Brienne is sharing a preview of a course, which is one thing that we are at AVAC trying to do, which is to break down sort of the use of mathematical models and how they can be used in policy and advocacy. So for those interested, we do encourage you to take it, but that's just one tool. Are there other ways that we can brainstorm to think about ensuring that these don't just sit on the shelf?
This is this course that that you've developed, and I feel like I have so many. This is such a tough question, but such a good one, and something that I struggle with a lot, because I think methods and methods development is often something that happens maybe more in like academic spaces, and sometimes can lead to just research for research's sake, or methods that are developed that aren't widely applied. And I think that there does need to be more done in terms of just creating forums and spaces to bring people together and create tools to make some of these methods more accessible, because I think that it will lead to developing better methods to address some of the questions that we can't answer now, and also to having them be used to really make a bigger impact on policy. And I think now what you're talking about to me is a tough one, because I do think it is an issue, and I don't feel like I know of that many tools off the top of my head that really bring groups together to think about, like, what are the tools and how do we use them and how can they be applied and used by ministries of health, and to create policy and to move forward in terms of how we think about social determinants and HIV. So,
it's always okay. This is a great space to say, like, sometimes we just don't know, and this is why we brainstorm together. And I would say that I think that this is, a first conversation amongst this group, and that this is the kind of dialogue that we want to have to both share these resources, and as the supplement comes out, help to make sure that these new methodologies are found, that advocates understand how to use them, community knows that they exist, and then begin to shape, like, how do we talk about prevention programs of the future? Because right now, a lot of the things that these studies have looked at are oral PrEP or cash transfers, but there's new and emerging elements that are going to be happening. And does this methodology, would it still work with a ring or with a long-acting cabotegravir injectable? Like, how and how do we adapt to that? So this is the first of, I'm sure, many conversations. So I do just want to spend a minute just to open it up to the floor. If there's any other questions, comments. If not, I do want to give everybody some time to think about some other sessions with IAS this week, but I just want to thank, our panelists, our experts so much, Dr. Greenwood, Dr. Stoner, Dr. Kim, for your time and for joining us today in this conversation. As a reminder to everybody, this will be shared on both our Engage platform, where you can find the modeling course, but also on our Research Literacy Networking Zone page on the avac.org site. And we'll share the recording to all those registered. But just thank you three so much for your time and your knowledge and sharing that with us today.
Thank you for the invitation. Thanks for joining.
Yeah, thank you. This has been great.
Thank you so much for the
Thanks for the questions as well.
Great. Well, thank you all so much and have a wonderful rest of your day.
You too. Take care.
All right.